So this is a case of NS2 cataract, and here I am proceeding with my first side port, Sujata HB lens. And here I go with my second side port. Usually I prefer a direct chop. So let us see how it will proceed. And if it is a very soft cataract, it's a case of PSS actually. So if it's a very soft cataract, we will go with flip and chop. If not, we get a grip, then we'll go with direct chop, because always direct chop is preferred. I prefer direct chop over other techniques. Sujata, देखिए program 2 अच्छी. So here I am doing my rexis. Usually in case of Phaco, the rexis has to be of 5 mm size, should not be larger than that. So if it is larger, again we'll have lots of problem. The nuclear pieces will slip out of the bag while emulsifying. The second, there will be little displacement of the optic of the IOL. That's the reason the ideal size of the rexis has to be 5 mm. Now I do hydro dissection. Blockage, metal. So here I'm doing hydro dissection. You can see the golden ring, and one part of the nuclear pole popped out of the capsular bag. That shows the delineation, the dissection was correct. That's Sujata, Phaco de. We'll just rotate the nucleus a bit. Lens नीचे. Now I'll just emulsify the superficial cortex little. The endonucleus is a bit hard, so I'm expecting I'll got to get a grip so that I can proceed with my direct chop. See how nicely the nucleus got divided by direct chop technique into 2 heminucleuses. Now each heminucleus I am dividing into further smaller fragments. Then I'll proceed with emulsification. So this is the direct chop technique. Usually for hard cataract or soft cataract I prefer this. If I don't get a grip, then only I proceed with other technique. Lens ready, Chandrika. So this is the almost emulsification is done. The last 2 pieces are there, and here always usually I do the emulsification on the plane of the iris, but if it is away from the last piece, we have to make sure it is the triangular part, the sharp edge of the triangular part of the nuclear piece is directed away from the capsule. Now I'll extend a bit the main port and the side port. Initially I don't give a large incision because there will be leakage through the side port, because I'm using the side port blade. If we use, there is one more blade comes, that is MBR blade. If the MBR blade we do with that, the side ports, then there won't be any leakage, so we can go a little larger incision initially as well. But this side port which comes in a triangular size, that if we slightly give a larger side port, won't leak happen. So MBR is always better. Our stock of MBR is over, that's the reason we are using this side port. So I am injecting the PCIOL into the capsular bag. If it is loaded properly, then the bag directly slips into the IOL directly slips into the capsular bag. No need for us to dial. See, I just adjusted it a bit, but it's already in the capsular bag. I'm just rechecking. Yeah, it is in the capsular bag only. We'll just wash out the visco. Sometimes we go, if the visco is more, usually I inject the IOL while irrigation, continuous irrigation. So see, I'm just going below the IOL, in between the IOL and capsular bag to wash out the remnants of viscoelastic substance. Now I will hydrate the side port. We'll give little intracameral moxie. Just 1 drop is enough intracameral. No need to give too much of, even lesser than 1 drop. If it is injected more, then we can wash out the outer chamber before hydrating. So this completes the phacoemulsification cataract surgery in case of a immature cataract in S2, where we did a direct chop. And the key word for any phacoemulsification is the side port. Though it's a very small point, but remember, never do a through and through side port initially, because throughout your phacoemulsification there will be wound leakage. Do a small side port at the end of the emulsification. Before the eye, you can extend the side port. Thank you.